All right, hello everyone, welcome. We are right at 3 o'clock, so we're going to go ahead and get started. Welcome to our webinar event this afternoon. My name is Emily Moore. I'm one of the project managers with the Southeast Mental Health Technology Transfer Center, and we're very pleased that you all are joining us for this webinar event today. Before I turn it over to Dr. Raney so she can start her presentation, I'm just going to share a little bit of housekeeping information. Please note that all of our work is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also please note that our center and the larger MHTTC network use affirming, respectful, and recovery-oriented language in all of our activities. And we do encourage that you use such language in the chat and in the Q&A if you'd like to share with each other during the event. I would like everyone to know that this event is being recorded and it will be made available on our Southeast MHTTC website for on-demand viewing in a few days. We encourage you to share all of your comments and thoughts throughout the presentation using the chat feature. And please remember to select chat with all attendees if you would like to share your thoughts and your questions with everyone. We have allotted some time at the end of our presentation for Dr. Raney to answer questions, but she will be monitoring the chat throughout her presentation and will either get to your question in real time after you post it or at the very end during our Q&A time. Finally, for participants who are interested, a certificate of attendance is available for download upon completion of our evaluation surveys. In the interest of time, I'm just going to go ahead and turn everything right over to Dr. Raney so that we can start today's presentation. Thanks so much, everyone.
Thanks so much, and welcome to everybody. And as Emily said, we really welcome, not in Q&A, but in the chat box. If you would, put your questions as things come up. We really want, as much as we can, we'll try to answer things in real time or save them for the end. So please use that. I'm Dr. Lori Raney. I'm a psychiatrist, and I work for Mountain Area Health Education Center in Asheville, North Carolina. I go back and forth between North Carolina and Colorado, work out there with the Ute Mountain Ute Health Center, where I've been with the Indian Health Service for, about 26 years. So very familiar with working in rural areas. And I'm excited to talk about this topic today. Just quick disclosures, I do receive some royalties for some textbooks I have written, but there's no pharmaceutical device or off-label discussion of medicine. Just to give you a sense of where I work, I work for MAHEC, which is the Mountain Area Health Education Center. You guys, in all the different states that you're in, AHECs are federally funded education consortiums for an area. Mine just happens to provide family practice, internal medicine, OBGYN, not all, and psychiatry, but a lot of the AHECs across the country, I mean, these are nationally, including in your states, are really nice education resources for all of you. So just in terms of thinking about, there's 300 locations across the country. So just wanted to give you a little background about where I work and how I do this work in mostly in rural areas. So let's get to the topic for today. I really want us to think about measurement-based care is really the happening thing in behavioral health right now. And when we walk away today, I'm hoping that you guys will have an understanding of what's an effective way of measuring behavioral health, what's ineffective, how does this work? I want you to have a sense of some of the common validated measurement tools for assessing primarily behavioral health symptoms in community health populations. We're going to talk about how a database where you collect that information, it's called a registry, how it can be used to really improve patients' care and population health. And then just that whole concept of employing serial measurement tools and how they can actually be used for patient engagement. We're going to talk about really a lot of exciting things around measurement-based care and how they kind of work for everybody. What is measurement-based care? It's really the systematic administration of symptom rating scales, okay? We've been doing this in medicine forever. We haven't been doing it in behavioral health as much, but what it is, basically, there's a lot of words here in terms of this formal definition. But at the end of the day, it really is systematic administration, okay? Not just at screening, not just at intake, not just whenever we feel like it or think about it. It's a very systematic approach, and we're going to talk a little bit about that. And there's two elements to it. One is you measure, and then one is you do something with it, with that information. Like I mentioned before, measurement-based care is not new. In the rest of medicine, imagine going in for your diabetes check or your hypertension check or your weight management check or your asthma or your thyroid, or even, if you have a heart condition, you get measured on with your EKGs. There's all kinds of, in medicine, we've been measuring forever. That's what happens when you go in, your temperature, your blood pressure, your weight, your oxygen saturation, that little thing they put on the end of your finger. We do that in the rest of medicine. We haven't been as comfortable doing that in behavioral health. That's a lot of what we're going to talk about today, but we really have reached the point where this is absolutely something that we can do. And one of the things I put in the chat box is just a really nice new resource that's come out around measurement-based care from the Meadows Institute. You guys might want to click on that and open it when you get a chance. Please promise me you're not reading it while I'm talking, so we can make sure that you get a really good grounding in what measurement-based care is before we share a wonderful resource with you. So this is not new. What's new is bringing it to behavioral health. Okay, so let's see here. Here we go. So what is measurement-based care? As I mentioned before, measurement is that systematic administration. How do I know when to administer the tools, how often to administer the tools? What does that look like? I want folks to remember that in behavioral health, our measurement tools, that we aren't as good as a hemoglobin A1C for diabetes, for example, but we're pretty darn close. There's not a substitute for clinical judgment because patients can kind of score in different ways based on who they are and how they feel. So it's not a substitute for clinical judgment, but it's an absolute supportive tool and a way to really track and think about folks. So we're going to administer those tools. We're going to do it on a systematic way. And we have to use that information to drive clinical decision making. It's not enough to just measure. It's not enough to do a PHQ-9 at intake when patients come in. And maybe you look at it, maybe you don't. Maybe you think about it. Maybe you share the result with the patient or you don't. What's the difference between a score of 9 on the PHQ-9 or a score of 19? What does that look like? We're going to use those results to drive clinical decision making. That's one of the, there's no sense in getting the results if they're not going to change what you do. Think about your blood pressure, your blood sugar, those things that you have done in medicine. When they check them, they change your medication, change the approach if in fact you're not getting better, or actually if you're getting worse. There's all kinds of great things that measurement tools can tell us. So we have to make sure at the patient level, we are using that information to drive care. We really want to make sure that we are kind of getting beyond any clinical inertia or whatever it is that we might have going on around that particular patient care. And I'm going to show you some studies and some ways that we really have seen that if you're not measuring, there's this whole pause before the patient is well. And we really want to push beyond that pause and just really think about how to tell if a patient's well. The other thing I want to say about tools, and I probably say this again later, is what's really cool about these tools is the patient rating the scale themselves is as good as the clinician asking them the questions. And I think it might even be better. Leave the patient alone in the quiet of the waiting room or the office before you come in and let them do it and do it thoughtfully on their own. But what we know is them doing it themselves, it's at least equivalent to us doing it. So sometimes people think they need to ask all the questions on a rating scale, and technically we don't. And there's good research that shows that the patient entering that is as good as us doing it, which if you think about it is a time saver, because there's a number of barriers to doing measurement-based care that we have found in studies. And I'm actually going to show you a really nice study that came out in JAMA Psychiatry a couple years ago that really looked at the barriers and the misconceptions and some solutions about what to do around measurement-based care. I can't imagine that as some of you are sitting here, you might be thinking, oh gosh, how can we do this in our organization? This would take a lot of time. Might this look like? What would our staff say? And just kind of thinking about the implementation challenges. And I want to talk about that. And in particular, in the chat box, if any of you guys have implemented measurement-based care in your organization, to sort of talk with us, we'll talk with your group of peers and colleagues on the phone about what that experience has been like for you. So this is MBC, not just M, but you got to remember the BC. You got to use it to drive care. Now, providers, our clinicians, often have some concerns, right? Is measurement really suitable in community mental health in our rural areas? And just, that concern about, really, do measurement tools replace clinical judgment? We've already said they don't, but they're an aid to clinical judgment. These tools, they don't work for people with serious mental illness. Well, depending on the tool, they absolutely do. And they've been used in research for years and years. And some of them are simple tools we can use in our community mental health center. And we don't need those tools. We provide a thorough clinical interview. We know this stuff. We don't need these tools. So these are the kinds of things, maybe the kind of pushback you might get from your clinicians, or you already have as you thought about implementing measurement-based care. Like I said, this is like the thing that's kind of sweeping the nation. Your state Medicaid agencies are starting to require it. And I'd be really curious, because typically we have 6 or 7 or 8 states represented on these calls. If you are having the situation already where in your state you're being required to do some measurement, turning in those scores and things around your state Medicaid funds. If you are a federally qualified health center or working with a federally qualified health center, you are also required. They have like 17 different measurements they have to report on for their Medicaid patients. So this is happening, but we really do need to think about our provider questions and concerns and their pushback about it as we sort of go through this talk today. And again, I'd be very curious for those of you who even if you've just implemented something like, we get the PHQ-9 at intake, we use that number to think about how depressed a person or anxious a person might be, and then we re-administer it at every visit, or we re-administer it at X period of time. I'd be really curious, really, how much all of you are actually doing in this area already, because it has become such a thing. So from the provider perspective, because you will get pushback. I get it. I tried to implement in the community mental health center where I work. Took a little bit of time, but it really had to overcome some resistance from my psychiatrist around it. But some of the things that you can think about when you're talking to your clinicians about it is, these are just a couple things we found around measurement-based care. One of them is how do we as clinicians really demonstrate value to payers, value to ourselves? We know there's value, but how do we actually demonstrate that? And it's really nice when you start seeing a lot of patients with depression and you start to see plenty of folks with their PHQ-9s drop. And we just started doing this in our intensive outpatient program. And even though we have some people that are very, very ill, very complex illnesses, it's just been wonderful for our whole team, really watching how PHQ-9, GAD-7, PCL5 for post-traumatic stress disorder, really watching how those scores improve. Sometimes we feel really undervalued in healthcare, and measurement is something that can really help us really demonstrate our value more. I think we have some concerns about, especially in behavioral health, that we're going to miss out on important alternative payment structures because we don't measure, because we don't really have a way to demonstrate outcomes. I remember all these treatment plans in the past where we would say things like, well, how are you going to know if the person's less depressed? And we're going to say, well, they smile more, smile 3 times during the appointment, or something like that. Good luck getting paid for smiles 3 times during an appointment, right? So measurement-based care is really a way for us as we move towards alternative payment structures to really demonstrate value and really think about what that looks like. Therapists, we give a lot of therapists who experience burnout and kind of hopelessness about their situation with their patients, because in our work, for those of you that are in community mental health, we're out there, we're doing the good work in the trenches with some people with some pretty severe illness. If we begin to measure and really look at what we're doing, that can really help some of that experience of burnout. We're not getting anywhere. Sometimes I want to think that with IOP because of our patients, and it's like, wow, it has been such an eye opener for our staff to really see what's happening, even with folks that have pretty severe illness. We rely in community behavioral on productivity standards. Did you meet your standard? 80, 85%, whatever it is. And how about instead that we also focus on improvement? So, to me, a quality metric is going to be so much more meaningful than to a staff member than did you meet your productivity? Did you meet your productivity and 60% of your caseload had a 50% reduction in their PHQ-9 score, or 20% of your caseload reached remission? Now we're talking real quality metrics. Yes, you're keeping up, but are we just, counting widgets to see how many we do, or are we actually now able to demonstrate quality metrics? And if you were in the rest of medicine, in an FQHC, you actually have to tell them what percent of your population had a hemoglobin A1C of less than 9. And you got to report that to HRSA. That's a quality metric. They're not asking how many gazillion patients did you see, what was your productivity. They're asking, what's the outcome of diabetes, low birth weight infants, hypertension? That's what they want to know. So these are quality metrics. And so we can make a shift from productivity, and it kind of gets us all frustrated and burnt out sometimes, to really thinking about quality. And then just really thinking about that unique individual level in a data-driven system. We can really look at how we're doing, how we as providers in an individual way are actually doing. Okay, so let's see here. The other thing that happens if we don't measure is that we really do miss important clinical outcomes. And this was kind of an interesting study that showed, research shows that in behavioral health, we don't really detect if the person's getting worse sometimes, that we really, really are missing that for a number of our patients. So that's definitely not something that we want to be doing. We really want to keep looking at how folks are doing. And that detection was even lower for those whose symptoms are not improving as expected. We don't know that people are getting better. Sometimes we don't know if people are getting worse in a more exacting approach. Okay, so it's quite interesting what happens if you don't measure. And this again is research in behavioral health. This isn't research in other parts of medicine. So we really, need to be thinking about what this looks like. And I was just looking at one of the comments in the chat. You use the PHQ on admission and on discharge, and that each outpatient appointment. Exactly. And then the question is, when you do that, are you also making sure that all those in between appointments, is the supervisor looking at them? Is the clinician looking at them? Is the patient looking at them? What are you doing with all of those scores in between? Okay. And that's a lot of what we're going to talk about today, because I do see a lot of PHQ-9s being given at appointments. And the question is, what happens with them? And what do you as a supervisor, for the folks that are supervisors on the call, what do you as supervisors do with that information in addition to what your therapists, psychiatrists, and others are doing? So this is where it gets kind of interesting. Now, payers, this is literally a quote from I think it was United Healthcare payer, who said, you know what? Behavioral health is a black hole. We pour money in and we don't get anything in return. Okay. That's part of that G in behavioral health. We don't really feel like we have a way to demonstrate value. We're going to get left out of alternative payment mechanisms if we don't figure this out. And so the payers really want outcomes, just like they want with diabetes and blood pressure. they really want outcomes. We keep asking, would you open this code? Would you open that code? Would you reimburse us more? Would you do these various things? And we really need to figure out a way to demonstrate outcomes. And so the move now towards measurement-based care and behavioral health lets us begin to do that, because the payers, we're really moving towards alternative payment mechanisms. So in my mind, measurement-based care is really a win for everybody. So for the payer, you can demonstrate value. For the provider, here we can now see what's working, what isn't, and know what to do with our patients, and know what is the quality of care that we're providing, but also on the patient level. One of the things we're finding, and this was just for me a bit unexpected, is sharing the data with the patient. Now, sometimes you have patients who they don't want to be on medicine, they just want to be in therapy. You have patients who want to keep going in therapy, and we've kind of run out of things to talk about. They really are looking pretty good. You have patients who might need a higher level of care. You have patients who, you've been talking about things that you think would be helpful, exercise, reducing alcohol, those sorts of things, and they haven't quite gotten into doing that yet. And one of the things I learned, and I would just kind of take the screen on my computer or on my laptop and turn it around and show the patient the numbers, show them their PHQ-9 scores, their GAD-7 scores, and really get them involved in, can we get that PHQ-9 below 10? Can we get that PHQ-9 below 5, which is remission? And for patients to kind of know what their number is with blood pressure and with diabetes in particular, patients know their number. They know what they're headed for. They know where they should be. And we can do this in behavioral health too. And so measurement becomes an excellent tool for a variety of different things. One of the things that I see is a lot of patients who are doing well, and we want to check in with them or do whatever instead of just discharging them. Their PHQ-9 scores are super low. And then you have to start asking yourself about medical necessity. All those patients we're holding on to for a monthly check-in, if their scores are stable, low, maybe they need to be discharged. And it's really not medically necessary based on their data that we keep seeing them. And so that actually gives us another pause. It actually gives us another way to talk to patients about this service. It's time to let go. And that is something, in behavioral health, we just hang on to people for years and years and years. And maybe there's a different way of interacting with patients around their care and what they need. Okay, so let's see. So what we're trying to do with these measurements and with the clinical history for the patient is really figure out where in the continuum of care a patient can be placed, should be placed, and how they move back and forth. Sometimes with behavioral health, it's like folks move to the right and they never come out. We really need to be thinking about the back and forth here. This is just a side comment about when patients are stable, can they go back to usual care and primary care when they need to be stepped up? So we end up, really trying to get best use of scarce resources. And you guys know behavioral health is a scarce resource. Many of us have either wait lists or we have long times out for patients to be seen and re-seen. We really want to use our behavioral health resources to the maximum efficiency. And so with lower scores, less complex, we really want to work with our primary care colleagues to see, how much of this care can go on in primary care, and then really save those of us to the right in specialty behavioral health, really save us for the patients who aren't improving in primary care, patients who might be too severe for their care in primary care, but also to know in specialty behavioral health when they can actually go back to primary care. And this is a huge issue for psychiatry. We hang on to patients forever, and many of them are stable. Their scores are stable. We could actually have them go back to primary care in order to get their follow-up, refills on those meds, that sort of thing. So these tools help us a little bit with finding that right level of care, monitoring their outcomes, and kind of knowing, the next place they need to be. If we do this, I really do believe we can increase effectiveness, number one. I'm going to show you a study on that in a minute, but also it lowers the overall cost of care if people are being treated in the right place. So our measurements, our scores, are paired with the clinical interview, really help us see where along this continuum does a patient need to be today, and where might they go back to, or do they need to be stepped up? So if they show up in primary care and they're too severe for primary care, let's step them up to specialty behavioral health, but let's let those scores help guide us in actually bringing them back to as needed. Okay. Yeah, here we go. Okay. So when you look, for instance, at this particular graph, and you think, who needs a higher level of care? Well, the person up on the left-hand side came in with some pretty high scores. PHQ-9 of 25, GAD-7 of 20, and really over the course of about 6 weeks, really began to bring their scores down, and about 8 weeks here, really, reaching remission. This is a beautiful, nice curve in terms of how a person's doing. And this person might have been treated in a primary care location. There's really nice response to medications, therapy, whatever they got, or coming into your behavioral health system, really nice response, okay? So this person at 2 months is doing really well. In typical specialty behavioral health, we may hold on to this patient for 6 months to a year, okay? And yet, if you look at the scores, what this begins to tell us is maybe it's time to wrap up with this particular patient. They've had an episode of their illness, they've had an episode of care, and now we can actually discharge them from this level of care back to primary care, wherever, and then that opens up a slot for a new person. See, that being more effective and efficient is what we're really looking for here. So just something for you guys to think about in your centers. How many patients do you have that may be hovering down in here and actually need to be discharged? They're well, and they maybe no longer meet medical necessity for the level of care that you're providing. This graph in the bottom, you can see this patient has had times when their scores, we're getting pretty close to remission, and then things would kind of peak and go back. So a lot of different things could be going on with this patient. They could have chronic pain, they could have a substance use issue. And again, this is why we say when you're measuring and using scores, you use them, with a dose of clinical judgment. Okay. Depression, as we all know, there's so many co-occurring problems. It's difficult to treat, especially in our community mental health centers. So this particular graph is just a nice example of what's happening with PHQ-9 and GAD-7 scores with a patient over time. Again, you can see a time when they're doing better and then just kind of peaks and relapses. Again, substance use, personality disorder, trauma, all kinds of things can be going on here. But what this may tell us is with this particular patient, we may want to look at our treatment. Maybe this person needs IOP. Maybe this person needs to go to substance use treatment. Maybe we need to coordinate care with their PCP around a problem with pain that they're having, just really thinking of what can happen around that. So this is just a really nice example of looking at the graphs and really kind of see who needs a higher level of care, who's doing okay, that sort of thing. Okay, so for those of you who may wonder, well, how do we know this really works? How do we know measurement-based care is a thing for behavioral health? This is the study that personally changed my practice. This was published in the American Journal of Psychiatry. So this was a study of psychiatrists who half of them used a measurement tool and half of them didn't. And what they found in this study is if you had a measurement tool, the patients got better much faster. See how this green line begins to drop down here? They got their improvement was seen, more dramatically in 4.5 weeks versus 8. Pretty amazing. Just really kind of thinking about what was going on here. And we saw a lot better remission rates, better, not only more patients going into remission, but getting there a whole lot faster. Okay. And this was a group of psychiatrists, people who, like myself, who we spent a lot of time with meds and patients and looking at them. And I used to say to patients, on a scale of 1 to 10, where do you think you are? And that was kind of my crude way of my crude measurement tool, or kind of how to think about it. And in this particular study, they use something called a HAM-D. We don't use that very much anymore. It's used more in research than in clinical practice because it's so long. They had a couple patients were all on the same meds. Again, greater response, shorter time to response. There were more treatment adjustments. That's what's different here, is the psychiatrists were making more adjustments, raising the dose, switching the medicine, they were doing more things because they had more data along the way. Remember, we talked earlier about sometimes we don't know how well a person's improving. We don't even know if they're getting worse because we're not checking. So they made more treatment adjustments, almost double. And this would be true for your therapist too. If something's not working, switch it up. I'm doing interpersonal therapy, the person's not getting better. Maybe I need to be doing adaptive DBT skills. Maybe I need to be doing motivational interviewing or something different. So they did more treatment changes by using the data to do it. It turns out, for these results, they actually used higher doses of antidepressants without a bunch of more dropouts due to side effects and other things. It really, for the psychiatrists and the meds they were given, it really pushed them to keep going. Don't stop at a PHQ-9 of 12, remissions less than 5, let's try to get them under 10, keep pushing. And it's what they actually found was they kept pushing the doses to really get people to the right dose. We didn't stop just below that. So this particular study changed my practice. At this point, I put a PHQ-9 and GAD-7 on the chair outside my office. I had my medical assistants with a clipboard, getting people to fill out PHQ-9s and GAD-7s. If diagnosis specific of PHQ-9, you don't give it to just everybody. You give a PHQ-9 to the people that have depression, major depressive disorder. You give the GAD-7 to people that have an anxiety disorder. So it's not just a global catch-all thing, but specifically for those diagnoses. And this just really, it changed my practice as a psychiatrist. And this study came out in 2015. Now, about a year later, this paper came out. And basically what this group did, and the work was really, the motivation behind it was the incredible results we had seen with the collaborative care model of integrated care, for those of you that are familiar with collaborative care. And what they saw in the collaborative care model was how people got better with a lot of really frequent measurement. PHQ-9s, GAD-7s, at least monthly, sometimes every couple of weeks, really a lot of opportunity to change treatment if you're really measuring that much. So these guys all got together and they said, well, let's look at the they looked at the world's literature on measurement-based care for behavioral health conditions. And what they found was we really are there. It's not perfect, but we really have reached the point where we can use measurement. And most of these studies, quite a few of them were done by psychologists who are very much interested in measurement and numbers. And they really took a look at using tools over time. And then these guys kind of pulled all that information together. This was work done as part of the Kennedy Forum. They published this paper, and they have some supplemental guides to tools that can be used. In the chat box, I put a link, which this paper came out in 2016. The new information came out in about 2021. So they sort of took this paper 5-6 years later and updated it. Otherwise, the tools that they demonstrated here are on the Kennedy Forum website. But this then it came out a year after the study that I saw, and I'm like, oh, okay. Well, this sort of validates too what I'm doing and what I'm seeing, and really got me to thinking even more about how do you spread this throughout behavioral health. Now, I do a lot of work in primary care, so also kind of thinking about what are those other tools in primary care, but it is your kind of standard PHQ-9, GAD-7, that sort of thing. So this is really the study that got the attention of all of behavioral health. The first one was a little one in a psych journal. This one really got the attention of folks, Medicaid agencies, individual practitioners, organizations, the National Council, the American Psychiatric Association, all kinds of folks started saying, whoa, we need to do something different. Look at this paper, look at this research. What they found was what doesn't work is one-time screening, or one-time at admission, we get a PHQ-9 and we never do it again. That happens a lot in primary care. Actually, depression screening is a major quality metric, but there's never anything that happens after that. So one-time screening does not change outcomes because you may act on it or you may not. And if you don't ever look again, how do you know if the person's getting well, getting worse? They smiled more often, I think they're okay. Again, try getting paid for that. That would certainly be a problem. What also doesn't work is assessing symptoms infrequently, once every 6 months, once every 3 months. It's not frequent enough for us to really know how a person's doing and what we need to do differently. And then just kind of sending, primary care or sending staff the numbers, the scores outside of a clinical encounter. You really need the information in front of you when you're seeing the patient and not this stack on your desk of, oh gosh, who are all these people? And I have all their PHQ-9s and GAD-7s. You don't have time to go into the record and try to address all that. It's really about having that information at the time of the encounter. So this is, in this huge literature search, these are the ineffective approaches to collaborative care. We're going to talk now about the effective approaches. So what are these commonly used screening and measurement tools? And again, I invite you to go back to the link I put in the chat box because it has a supplement to it that has an amazing list of adult, child screening tools. But these are just some of the common ones. Of course, the PHQ-9 for depression is used pretty much everywhere now. You may have other tools you use. Some people will use the postnatal screening tool. The GAD, and now these are full GAD-7, full PHQ-9. They're not the twos. The PCL-5, this comes out of the VA, but this is the civilian version used for post-traumatic stress disorder. The SCARED is a scale that can be used for children under the age of 12. Really nice. Let's see if I can repost that. There you go. Really nice tool for child anxiety with a number of subscales in it. Again, the PAN-6 has been used quite often in really looking at response to antipsychotics and treatment with the SMI population. And substance use, the full audit asks a lot of historical questions, but the audit C stands for consumption. What we're trying to do in substance use is reduce consumption. That's really our goal. And then the BAM is another tool that's often used in substance use. So these are some of the common ones, but there are others we're going to talk about in a minute. Now, my hope is that you guys have seen the PHQ-9, right? This tool has been around for a while. It asks about it. These are the 9 questions for depression in the DSM-5. So write down the list. It actually is very helpful for you diagnostically, in addition to giving you a score. A score of 10 or more is in that moderate to more severe range. So that's really where we're going to get activated to do more. And that's what we tell our primary care colleagues. Hey, 10 or above, we need to get them referred internally, we hope, to an integrated care service. There's some watchful waiting, and then there's remission at less than 5. So this is probably the most commonly used tool for depression. Remember, this is not a catch-all and tool for how is everyone in your population doing. It's specifically for depression. But I really like that it's the patient health questionnaire. It's not the patient depression questionnaire. Because for patients, I think this is just a nice way to say it. Again, the 9 symptoms of depression, and here's how mild, moderate, severe is thought about in this tool. The GAD-7, generalized anxiety. These are the 7 symptoms of generalized anxiety disorder, but we use this for panic disorder, also in social phobia. So it can actually be quite helpful. Again, score of 10 or more, we're thinking that we've got, something going on. We want to interview the patient and see what's up. Okay. Remember, we're going to use our clinical judgment. We're going to interview the patient too. Sometimes patients will just take and circle all the 3s because they're feeling awful. And maybe they're not totally threes. Maybe there's something else going on. They're just having a bad day. And sometimes they'll circle all zeros when it's really clear they're anxious. So this is why you have the clinical judgment. People doing that under and over reporting is not that common. Most people are pretty thoughtful about where they are. So that is one of the things that we worry about. And here's just for child and adolescent. This is the Vanderbilt. Pediatricians have been given the Vanderbilt for years to make the diagnosis of ADHD, but we tend not to see it used so much in confirming response to care, remission, kind of where is this kid. Child psychiatrists have been using this actually for years, this and the Connors before that. So there are, again, specific scales for children, adults, substance use, etc. And then for people with more serious mental illness, we have, as I mentioned before, we have some nice tools that can also be used. The Altman Self-Rating Mania Score, again, brief, easy to score, self-administered for the mania side, for depression, PHQ-9. We have some for if people are going back and forth. Schizophrenia, I mentioned earlier, and then substance use conditions. So we don't need to shy away from this because we say, oh, the person's got schizophrenia, these tools aren't helpful. Well, in fact, they can be helpful. So we don't want to shy away from it in patients with more severe illness. We also want to think about, and I think someone mentioned this earlier, about functional measures. We don't want to leave out, especially like think about kids, or how are their grades? Are they coming to school? What's going on in a functional way with kids in school? But what are those assessments that we can do? And there's quite a number of things. We use the health related quality of life. The HUDAS is really popular right now. There are just a number of things you can use, and many of you are probably already using these. If you get Medicaid funding, most of us have some sort of tool we have to use. A lot of those tools that are state generated, to me, aren't all that helpful. There's not a lot of ways to move up and down those scales. But a number of these can actually be quite helpful. And we really want to know how's the patient functioning in addition to their level of symptoms. Hopefully symptoms improve, functioning improves. We just want to make sure that people are moving along that trajectory. And sometimes maybe the symptoms on our measurement scales aren't, but they're functioning better. A homeless person that's moved into housing, something different is happening along a functioning level. So again, ways to get credit for folks improving, where it may not very, discreetly being showing up in a particular measurement tool. And I think someone had asked a question about that earlier. So what's the process of measurement-based care? The first thing is we use it when folks come in the door. So we do that screening, we do that assessment at the beginning. Now, I always think it's kind of weird to talk about screening for depression. If someone comes in and says, hey, doc, I'm depressed, I don't have to screen for depression. They're telling me they're depressed. Now I'm going to match it up to the DSM-5, and in this case, PHQ-9, and see how the symptoms. So we're doing that initial PHQ-9, GAD-7. Sometimes people do, 3, 4, 5 screening tools when folks walk in the door, establish a diagnosis, start treatment, and then measure, a systematic approach to measuring. Not once every 6 months, not once every 3 months, once a month. Most of these tools are absolutely fine at once a month, and some are, you can actually give them more. What you look for is that first question. In the past month, how often have you felt? In the past 2 weeks, how often have you felt? So the PHQ-9 is the past 2 weeks. I think the PCL-5 is in the last month. So they actually kind of give you in the language what this can look like. But this needs to be very, very systematic. You're tracking it, and then you're adjusting treatment. If you measure the response and the person's not getting better or the person's getting worse, we're going to adjust treatment as needed. And then we're going to feed back those results. We're going to also do some tracking of this, which I'm going to show you in a minute. When you think about the workflow, if you're like administrator of a program right now and you're listening to this, you got to figure out what tools are we going to use, how often. This is the systematic, right? How often are we going to repeat them? What are you going to do with that data? Who's going to administer? In my case, it was my medical assistant. It could be your direct care staff who are doing it. It could be the front desk, and they have an iPad at the front desk. Who's going to put it in the electronic medical record? Where in the electronic medical record is it going to be locate them in organization right now, they put it in 5 different places. So who knows? If we're trying to standardize that. How's it going to be used by individuals, families, and then what are we going to do when we put it all together to really assess how an organization is doing? So where do we put this data? Well, one of the things, because we want to be able to put it all together and say, how's our clinic doing? If you had to report this out to state Medicaid or HRSA or whoever, you got to have a place to put the data on, when they came in, this was their initial GAD-7. When they left, here's their final GAD-7, or they've been in for 6 months. Here's how their GAD-7 has gotten better, worse, or stayed the same. So you actually have to have a tool to do that. How do you extract it from the electronic health record? How do you aggregate it and think about it? So a registry is the population health tool that we tend to use. And again, it's a very systematic collection of, we decide up front what we want. In all patients with depression, we're going to collect the PHQ-9. All patients with post-traumatic stress, we're going to collect the PCL-5. And all patients with 3 or 4 anxiety conditions, we're going to collect the GAD-7, but it's very defined. What is that data? We can't collect everything. You could try, but it's really hard to collect absolutely everything. So we're going to really say, what is that data set? If you guys have patients with schizophrenia in your organization, many of you are collecting lipid panels, hemoglobin A1C for diabetes, you're doing BMI for weight, you're doing tobacco, you're doing blood pressures. You got very specific things that you're either required to do, maybe you're CCBHC, or that you're doing as an organization as best practice or as required by Medicaid. So clearly defined set of what that data is going to be. It can't be everything. You don't have enough time for that. And then it's in a central database that can be Excel spreadsheet, that can be a registry built into your electronic health record. It could be an external registry that you purchase. It can be a business intelligence tool that you use to take the information out of your electronic health record and put into a package. Many of you probably have things that you're already using, and then they can really serve different purposes. They can inform a payer of how you're doing. You can use them for risk stratification. Gosh, 25% of my population has lipid panels that are really, really high, or who have PCL-5 scores that are super high. We need to think about a program for trauma. Maybe we need to get DBT going. We really kind of need to think about what are those different things we're going to use that registry for. And a lot of it, I think, as we mentioned, before about, what's the value for providers, is really helping people see, patients improving, not improving, and actually changing within our program if we need to. What can it do for patient care? Well, we can actually make sure no one falls through the cracks. One of the things that happens a lot in behavioral health is if a patient misses an appointment, in our organization, we would say, it's the patient's responsibility, call me back. And really, from a population health standpoint, that's actually not best for patients or for the population that you're dealing with. So what a registry can actually do is show you who's fallen off, who's not engaged, who no-showed for an appointment we haven't been back in touch with, but now there's a big blank where their data should be. So it can really be helpful for just making sure no one falls from the cracks. And then it points who needs attention. Not everybody in the registry needs to have a treatment adjustment. A lot of them are doing just fine, but the ones that really pop out that need immediate attention, or who need adjustments in medications, really kind of see, oh my gosh, their numbers aren't changing. We need to do something better. And then we can use that registry for communication. I always, when I talk to the behavioral care managers in my primary care practice, they start their discussion with me with Mr. Jones came in with a PHQ-9 of 16. They've learned, just go ahead and start with what the score is and a history of depression and anxiety on X amount of Lexapro. PCP doesn't know what to do. What should I do? They almost know, start right there, because they know I'm going to ask to see, what's going on and what we could do next. And then this is what the registry looks like in terms of, having information that you can utilize, right? So here is depression scores. Here are all the patients with depression, and you can see who's getting better and who isn't. Who's kind of, not very much change here, a lot of change here. This is starting to go in the right direction. Same thing over here with GAD-7 scores. These 2 patients at the bottom have actually reached remission. PHQ less than 2, GAD-7 less than 3. We can see who's had at least a 50% reduction in symptoms. That's our first clinical target in behavioral health. And then who's reached remission. Okay, so keep in mind that 50% reduction, that's actually what the FDA requires to get your new antidepressant or your new antipsychotic or other medications approved, is a 50% reduction in symptoms. So that's what we're looking like first. Hopefully it'd be great if we could actually reach remission, but as most of you guys know, remission can be tough. We want it for everybody, our family, ourselves, our friends. We would love them to get into remission, but it can be hard, especially in rural and in community behavioral health centers. So we're going to measure change over time. This is the important thing. And if people aren't getting better, we're going to do something about it. And then, here's kind of an example of what your metrics might look like. Okay, remember, we talked about that 50% reduction. We talked about remission, and these are National Quality Forum standards. These aren't things we just picked out of a hat. These are real measures that have been on the books for years. We just haven't really been using them. Okay. And when you think about measures, we have process metrics, which we've been using in behavioral health forever. How many people got screened? What's kind of happened in terms of appointments and those sorts of things. Those are process. What's the process of taking care of someone in a behavioral health organization? And those tend to be the ones our state Medicaid agencies have been asking us to report on forever. Outcome metrics are what we're talking about. Look like in terms of real-time tools that we're using to see if patients are better or worse. We've been doing patient satisfaction surveys forever. My organization's always done them. The functional assessments I mentioned earlier, I think these are super important in terms of looking, from homeless to housed, from not working to working. What are all these different things, from bad grades to good grades, poor school attendance, good school attendance. So the functional ones are important, and they can certainly be used, I think, for especially looking for outcomes and thinking about your organization and payers. And then, the holy grail can sometimes be this utilization data, but believe me, that don't go after costs. Don't tell a payer you're going to bring down costs. This takes a little while. This could take a couple of years to actually realize the utilization costs. So don't jump in there and say, hey, if you just give me more money, I'll show you I can reduce this, because it may take you a couple years to reduce it. Maybe your payer wants you to reduce it right now. So just be careful with that particular one. And then this is an example of using a dashboard. This is what we had at my organization in Colorado. Is we were able, and this was just a computer on the wall. You see up here, this is my colleague Margie, and Margie, our computer was up on the wall. You can see her keyboard down here, and the patient's standing over here behind her, and she's able to point to PHQ-9, GAD-7, and this is vital signs right here. We're able to literally point and share this information with patients who are glancing at the board. They're glancing at their scores. She's having a conversation with a patient, maybe about weight loss, maybe about the GAD-7 score, maybe about their alcohol consumption. You're able to have that conversation and get the patient, really involved in their care by being able to show them too what is going on. So yes, it's helpful for us, but boy, how cool is it to make it helpful for them? How you want to share the results is up to you. This is one clinic I worked in. This is the nurses. Here are all the different quality metrics. Here's the clinic goal. Here are the providers. This is blinded. They didn't put their name up here. So blinded or not, what kinds of rewards? The carrot approach is, hey, we want you to reach this. We'll give you some bonus if you do. And the stick approach is, if you don't do this, you're in trouble, sort of thing, the carrot and stick. And if people reach their benchmarks, here's some benchmarks they're actually reaching. Maybe you actually want to set a new one. But this was right outside my door, and this was for the primary care providers in the Indian Health Service clinic. I always like to show this because it doesn't have to be on a fancy spreadsheet. Put it up on the board. Now, so implementation science is really, we're starting to really catch up with what has this been like doing it out in the field. There's a really nice article that just came out in JAMA Psychiatry a few years ago, where they're tried to implement measure-based care in behavioral health settings like yours, okay? And this is just a bit of a summary of some of the things we've talked about, but also as you're thinking about this and will this work in my organization, what's going to happen with this for us, is the barriers at the patient level is sometimes the patients will complain, especially if you do it too much. I filled this out the last time I was here. Why do I have to do this again? I'm really worried people are going to see this and think there's something wrong with me, that kind of stuff. So there can be patient level concerns. So I always say, don't over screen them. Don't do it so much that it just becomes, kind of white noise to them. You really want to do it in a systematic way. Remember our original definition, a systematic approach. And then, of course, at the clinician level, these measures are no better than my judgment. I can tell if someone's getting better or not. I had a primary care doctor tell me this the other day. I don't need a PHQ-9. I can tell when they walk in if they're laughing or not. It's going to take more time, more effort. I don't have time. I got a lot to do in this appointment. And, if I do this, I don't want to do this because if my PHQ-9 scores aren't good, then I'm going to be in trouble. I'm not going to get a bonus. I'm going to get written up. And you really do have to be careful. And this was in the chat earlier about if you have a really, if you have a population with a lot of behavioral health burden, you're on an ACT team, that sort of stuff, you really do need to be careful. You can't just say, well, any person on a ACT team who also has depression, if those PHQ-9 scores aren't up there, you're going to have to explain to me why. You really need to be thoughtful. This is a population where those scores may fluctuate in ways that don't quite fit because of the underlying psychotic condition. Maybe we need to look at functional measures instead. So you could see where your clinicians could be worried. Oh boy, I'm gonna get in trouble for this if my PHQ-9 scores aren't. I don't even want to do it because I'm gonna get. It's just going to be used in a negative way. And then at an administrative level, those of you who are administrators are sitting here going, oh gosh, we don't have the money for this. What are the resources for training? The administrators are responsible for supporting, reducing barriers, doing all those good things. And so, oh gosh, what's that going to look like? And, what are the different solutions here? When we think about the implementation science, we really want to monitor fidelity. We got to be really careful if we set out this course, what's that going to look like? Help by developing algorithms for how this is going to be done. You want to put together that workflow. You want to utilize brief, strong measures that really capture and brief and non-proprietary are really some things to think about. You may have local champions. You may have a primary care or a psychologist or a psychiatrist who's really into this. You can have think about how to do this, getting everyone trained, and really kind of generate incentives for it. Finally, I just want to say, depending on the results that you get, what do you do about them? You really want to think about continuous quality improvement. Many of you are familiar with PDSA cycles, where if something's not working, how do we fix it? What are the changes that can be made? Let's put a plan in place. Let's carry it out, and then let's see what happens. You can do this even with your implementation of measurement-based care. We're going to implement it. We're going to write it all out so people know exactly what to do. We're going to try measurement-based care for 3 months, and then we're going to sit back and ask what happened with that. So really think about PDSA cycles in the work that you do. And that wraps it up. I want to kind of go quickly to our chat box, and I'm going to turn it back over to Emily for a second. So the slides, the PHQ-9, the BAM, all those good things, go to that link for the Meadows Institute. And all of those are actually included in the supplement. Any of them that you just Google, you'll actually get the PDFs if they're non-proprietary, if they don't charge you for the actual tool. And I think I've gotten most of the stuff in the payment tied to outcome can be tricky. Absolutely. We need to really think about, functional measures, other things that might be necessary. And then let me see, there might be a question in the Q&A. What's the research say about patients involved in a score skewing results because they want to be a good client? Yeah, I mean, I think having a lot of research around that, and we don't really have so much right now. And I think that's actually a valid point in terms of thinking about it. I've been worried about patients on disability really wanting to stay on disability and really worry that they might lose their disability if they improve. So that's definitely something that we need to consider. It looks like there might be one new repost the link. Everybody see that? Okay, we're almost at the top of the hour. Emily, I'm gonna turn it back over to you.
All right, thank you so much, Dr. Raney, for such a great presentation. Everyone, I have put our SAMHSA required evaluation survey link into the chat. If you want to fill that out while we're still on the call. If not, you will be redirected right to that survey after the Zoom call is ended. Filling out that survey really does help us learn more about how we can improve and continue to provide events like these in the future. Please reach out to us at info@southeastmhttc.org if you have any questions at all. And that is going to conclude today's webinar event. Thank you so much, everyone. And thank you again, Dr. Raney, for such a great
You're
presentation.
welcome. Thanks, everybody.